The decision to advise a patient to undergo a transplant is based on several principles. The first principle is that by far the best treatment for any patient with AML in terms of preventing leukemia recurrence is an allogeneic transplant, which is transplant from a donor. Now you'll ask me then, why don't we recommend it for every patient if that's the treatment? And the answer is, we've got to bear this in mind, and this has to be where progress has to be made because of the consideration of toxicity. There is significant morbidity and mortality compared with an autologous transplant or chemotherapy without any transplant. So here are the principles, and without going into all the details, basically there are three groups. I'm going to use a terminology that I hate. There is a favorable group of AML. You need to know up front there's no such thing as a favorable AML, almost as if something one has been wishing for, but it's a relative term. It ought to be known as standard risk AML. And that's the group, if you think of it, where the benefit of transplant, of an allogeneic transplant, when we consider the risks, do not outweigh all the risks. In other words, you probably need to have an advantage of close to 15% in reduction relapse rate, between 10 and 15%, to justify such a decision. Now, into that group usually are the inversion 16s, the A21s, the CEBPA alpha, the biallelic ones, and NPM1 positive if FLT3 negative or low. Now you need to know that there's a great deal of arbitrariness here. And I'll give you an example. The whole world has accepted that if you're NPM1 positive and FLT3 negative, you should not get an allogeneic transplant. It's become standard of care. But if you look, we're supposed to be scientists, and what it's based on is not very solid data. It was one paper by Richard Schlenk and company, wonderful group in Ulm, 2008, I believe, New England Journal of Medicine, where 30-odd patients had a donor, of whom only 80% of whom actually received a transplant, and they did no better than chemotherapy alone. However, that's small numbers. For chemotherapy, we'd never, ever consider such a small number. So it's not a surprise where several years later, another group, the SAL group, the first author was Rowe, showed the precise opposite, that transplant do better, but it made no difference. Such is the dynamics of doing a transplant. You need one paper not to transplant patients, and if it's in New England, nothing else that can happen. So scientifically, we should be back where we were, that we should transplant it, which is what we did 15 years ago. They were intermediate group, but it remains so. Now, so much so for an allogeneic transplant. The data, if you're careful, for patients who don't get a transplant and are fit enough, probably the data support an autologous transplant as the best form of therapy for any patient who does not go on to get an allogeneic transplant.